So thematically, in keeping along with what Dr. Bedazzi just discussed, we're in the perpetual mode of looking to make a better outcome, and a better outcome for who? A better outcome for our patients. And that means a more predictable return to sport. It also means a more predictable avoidance of re-injury. We talked very importantly in the last few minutes about how therapeutically we can change things, how a little bit more time and how awareness of psychological readiness changes the field. So now I'm going to switch it up a little bit, pivot, and I'm going to talk about in the operating room, what are some of the things that we can do to avoid re-injury. And I'm going to talk about what our concerns are, our surgical improvements, and I can't help myself, but I do want to talk a little bit about post-surgical pain and the avoidance of opiates, because that's something we've worked on for the last decade and successfully. So there are 250,000 ACL injuries a year, 1 in 10 athletes. That's a pretty scary thought. That means a couple of players on every team. So this problem touches each of us. And historically, we believe that you'd be fine. You're going to go back to playing sports. However, if you look at everybody, maybe the risk of re-injury is reasonably small. But if you look at young athletes, the risk of re-injury is reasonably high. And the challenge is that, why did this person age 14, 15, 16 tear their ACL in the first place? Because they were playing sports? Of course. But maybe there's something about that athlete's anatomy or preparation that we could have made better. So just to have a little fun when talking about the surgery, we're going to get in the operating room now. There are many different types of grafts, replacements, whether the patella tendon, your hamstring tendon, or your quadricep tendon, all of your own sources of tissue. Rarely in our organization do we use cadaver tissue in an athlete. We just don't find that to be as successful, and that's borne out in the literature. And what does an ACL look like? Well, here's looking inside a knee. That's someone's torn ACL moving around, not attached properly. And then as we go to reconstruct the ACL, we'll create sockets, channels, holes, whichever language we want to talk about, and that socket will be where we put the new ACL in. We will then draw the new ACL graft into the joint using some sort of shuttling system and looking arthroscopically, and there's the new ACL. And at the end of the surgery, there is a graft. And I purposely have chosen different pictures to get some representation of what it really looks like. But amazingly, this is what we see. It's not some sort of obtuse, not clear, bloody field. This is a surgery of millimeters. Great, we fixed your ACL, that's it, go back, play sports, get back on that Division I field. Well, it's not as rosy as you think. As Dr. Bedazzi pointed out, it is a 9-month gruel, and it is not easy, and it is not simple for everybody, and there's a huge commitment, both physically and emotionally. However, I think there's some truths that we need to become more aware of, especially in the youth athlete and then the female athlete. 29% in one excellent study from the Mayo Clinic, 29% of athletes within 2 months of surgery in a high-end group had a second ACL injury, whether that's a re-injury of their primary or a second injury. That's really a scary thought, because if you ask a surgeon, they'll say, oh, it's 4%. And 4% is the data that we were taught, and 4% is including all the 50-year-olds like myself who tear their ACL. Then, if we look even more specifically at elite soccer players, in a European study, 68% of these women over a 5 to 10 year window had more surgery. So this is in and of itself an epidemic of challenge, 4 times greater risk. So the question that we have to ask ourselves is, we've gotten better at the therapy, we've gotten better at the psychological readiness. Can we be better in the operating room? And I would submit to you, yes, we can. And for those athletes who are at high risk, we are now looking at changing their surgery from just an ACL to adding a second ligament in. We didn't make up or invent this second ligament. It's called the anterolateral ligament. But now you will routinely see us perform an extra ligament reconstruction on the lateral, on the outer side of the knee. And there are 2 popularized words for them. One we call a Lemaire, one we call an ALL. Let me just show you what these look like. Here in this Lemaire procedure, I make an incision on the outer aspect of the knee. And I'm looking at the iliotibial band. And I'm going to take a portion of your own iliotibial band and reroute that and put in a second limb. So that's the iliotibial band right there. And I'm taking just a thin 8mm strip of it. I leave behind most of the iliotibial band. Then I'm going to find the lateral collateral ligament, which is that structure right there. And I'm going to loop the iliotibial band underneath your lateral collateral ligament. And by doing that, well, I'll do a little preparation to get it ready, but by taking that additional slip of iliotibial band and securing the outer part of the outer part on the knee, right there, I'm showing a demonstration of what it looks like. And there it is in real life. I'm adding an extra buckle, I'm adding extra stability. We're careful not to interrupt the ACL reconstruction. So now in the top corner, I'm looking up at my ACL reconstruction. And this is real time. This is how fast it happens. It's not some additional hour or hour and 15 minutes of surgery. And by reconstructing the outer part of the knee, I've added an additional lateral constraint. The other way that we might do this is called an anterolateral ligament reconstruction. And here, in this video, let me just get that sound off. Good. In this video, you can see through tiny percutaneous incisions, we're going to use a cadaver graft. And this is not for the ACL, but just to create the lateral side. And I will put this graft down onto the femur, affix it onto the femur, and then I'll channel it underneath the bone. In the same way as I affix it, I'm going to look up and make sure I'm not injuring my ACL. There's Dr. Vidazzi in the OR with me, actually. And I'll fix it into place. So I've shown you two different situations where we're adding, in two different styles of techniques, adding a second ligament to our ACL reconstruction. And does this make sense? Well, as it turns out, it makes a lot of sense. Not in everybody, but in the high-risk athlete. Remember, I just cited to you studies that suggested 29% of athletes re-injury. 60% of athletes, female soccer players at an elite level, are going to be back for more surgery. So now, when we look at what's happening, when we add an additional secondary ligament, you reduce the risk of re-tear by 2.5 times, by 3.5 times. Graft re-rupture less likely by 3 times. Looking at elite skiers had a 34% re-injury rate. These athletes crash. They're going nearly 100 miles an hour. You add this in, they went down to 6.5%. So it's not just me who believes this. It's researchers from all over the world who are re-examining what we're doing, wondering how we can get better, and by adding this ligament in, we get better. So Mark challenged me with looking at the ONS experience and how are we doing. This is actually a real picture. And those of you who may or may not remember, Schwarzenegger and Stallone had surgery on the same day, and they were very proud to be with themselves. However, these two elite Division I athletes, they are like, look, we're going to show those guys who's tougher. We can smile and laugh, but what upsets me is that there's 3 ACL injuries between those two girls who are both playing Division I sports. And the question is, how can we be better? And we can be better. So we look back on, just a microcosm. In the last decade, we've addressed the meniscus, and we fixed the meniscus much more commonly, particularly these root tears. We have really done a fantastic job on pain mitigation, and I'll touch on that in a minute. And now we're really readdressing the lateral side, how to make the competitive athlete less likely to re-injure. And we look back at the last 165 cases, right? 97% of them return back to their previous sport level, which is really unheralded. There were 5 reoperations, right? 3 of those 5 were on the other leg, so we felt pretty good. And we had 2 re-tears, in being candid. That's down to 1, that's about a 1% number. Much different than the 29 or the 68%, and actually more consistent with the 3% numbers that the elite authors are publishing on. So we really are paying attention, and not only are we paying attention and modifying what we're doing, but we're measuring what we're doing to be honest and critical of ourselves. So sort of the takeaways on this in my last minute or two, the anterolateral augmentation, the ALL ligament, it increases the rotational stability. So who do we do it? If you're young, right? Well, you're all young in this room, but I mean if you're young, in your 20s or younger. High-level pivoting sports. If you're going to play soccer, lacrosse, any type of NCAA sport, females are at a higher risk, and those individuals who have looser knees or more loosely ligamented are going to be candidates in whom we're going to consider this. And it's a pretty routine application. So just touching on my last 2 points, pain management. We, for so long, have been talking about the opioid epidemic. Each time I get up here, I think we're making progress. And each year, we still continue to have a lower mortality rate in the United States, much related to motor vehicles and opioid death. And the pandemic really set us back as we move forward on this. But what we're critically aware of is we reduce the exposure of opiates to our kids by fact. We realize that they're vulnerable, they're alone, and they're isolated in this moment after injury. They're not in their normal social circle, and we just don't rely. We don't rely on the medications. So for those of you in the OR with us, we're so attentive to our preoperative medications, Intraoperatively, we're using alternative blocks, and postoperatively, we're really limiting what they give them. We're using medications like gabapentin and anti-inflammatory and Tylenol all in conjunction, so they have a synergistic effect. We're using long-lasting blocks, and we sometimes have to fight with the systems to get the right medications, but we do, and we win, and our patients are doing phenomenal on that. We've published on this. We've actually led the country in demonstrating protocols on how to minimize pain postoperatively. Dr. Vidazzi suggested that early physical therapy is a critical part of the recovery, and it's also a critical part of pain management, getting that knee moving. So having and relying on our team of therapists is an essential part of that. So the last two slides, the hot news. What are we looking at right now? If you watch the NFL this year, you've seen Aaron Rodgers, you've seen innumerable ACLs and Achilles injuries, and it's been a little unusual this year, and much of the attention now is focusing on the turf. Is the turf part of the problem? And I would submit to you that it's not just the turf. I would use this word, it's the interface. And it's the interface between the foot and the turf. Well, we can't go around and change the turfs at all of our local schools. That's not a pragmatic thing, and we're not going to shut down sports all over the country. However, we may be able to modify the interface, meaning the shoe that the athlete is wearing. And we're looking at a study now looking at turf shoes versus cleats. And athletes don't want to slip on the field. When they're running, when they're cutting, when they're dodging, they want to pivot and move. They want to move faster, and the turf allows you to do that. However, we have shown in a group of 300 college athletes, female lacrosse players, that if you're wearing cleats with long studs on them, you're at about 1.5 to 2 times risk of tearing your ACL as opposed to wearing a shoe with lower cleats. So we're going to publish that this year, and again, that's going to be one of our pushes. Look at your shoe wear, look at the surface that you're playing on. So hot news, beware of that. So in conclusion, look, for our ACLs, we're going to use your own tissue because the data suggests that that's going to be the best. In the young elite athlete, we're going to repair your anterior lateral side with either a lamella or an anterolateral ligament reconstruction. Pain should not be a fear factor, and pain should not be treated with opiates as a first line, and we've demonstrated that for the past decade successfully. And finally, beware of long spiked cleats. They may look cool, they may make you feel like you can cut better, but they may be an injury maker. With that, I'm going to move on. I believe Dr. Delos is next. Thank you.